Namaskar. I'm Dr. K.K. Agarwal. Welcome to our weekly show, a webcast which is being attended by most of the doctors in the country and also the healthcare providers. The subject which we are discussing, which we have chosen today, is something which we have never discussed in the past. We have covered emergencies, medical emergencies, but specifically covering pediatric emergencies, we thought it is of interest to a practicing physician. I have with me Dr. Anup Mohta, who did his MBBS, joined MBBS in 1979, did his MBBS from Maulana Azad Medical College, then did his MS from Lady Harding Medical College, then did his super specialty again at Maulana Azad Medical College. He is the first super specialist graduated from Maulana Azad Medical College. Currently, he is the director professor of Chacha Nehru Bal Chikitsalaya, an autonomous institute under Government of Delhi, which is affiliated to University of Delhi and associated to Maulana Azad Medical College. Welcome to our show. So, Anupji, when we talk about, suppose let's talk about 7, 8, or 10 common pediatric emergencies in whatever time we have. The first is, for me, the most important which comes is injury. So whenever there is an injury, because children are all the time playing, they are playing in the cricket ground, they are playing in the football ground or in the school ground, and the health of the soil in our country is not good. Soil is contaminated, so they have chances of infections, they have chances of tetanus, and apart from that, there is an injury. What to do?
So injuries are something which we see almost every day in our emergencies, and they are a major cause of morbidity in children. And if they are involved in an injury because of a road traffic accident or major accident, they can be a cause of mortality also in children. So basically, first thing I would like to go is about the prevention, which we all know that for road traffic accident, we should be following the traffic rules, crossing and not jumping the gun and red lights and all that, not playing on the roads and playing the grounds, etc. So apart from this, now when you come to the injuries as such, it depends on the type of injury which you get. Generally, while playing in a playground and a cricket ground or playing football or something like that, when we fall on the grass or we are pushed by some other player, what we get is an abrasion. And then we can have bruises, abrasions, sometimes there are cuts. Now, depends on where do you get the cut and how big is the cut. Now, whenever he gets an injury, obviously the child has to be given rest, he is to be isolated and taken care by the physician. In first thing, immediately we will do is wash the area with ample water, running water, and clean area with some antiseptic solution which if it's available. And if there's a cut, obviously we have to do in a playground. If you have a first aid kit, definitely it's a preferred item to have when in a playground. So we have an antiseptic solution, then we do a pressure dressing till the time we can give them a definitive treatment. Depends on the cut also. If it's a clean lacerated wound, yes, we can go ahead with a primary suturing in the center where the facilities for that are available. We clean the area and do the primary suturing and give antibiotics. And if it's a lacerated wound, a dirty wound, then I would personally prefer to go in for a delayed primary suturing. That is, after the infection is settled down or it's prevented, then I would go in for a delayed primary repair of this wound.
So what Dr. Anup has said is that two things. One is that your compounder, your nurse, or on phone, whenever you say somebody calls you up and say that my child has fallen down, two things public can do. So therefore, that's your duty to educate your patients and their relations what to do at home. One is to stop the bleeding. So you can do a pressure, you can put a pressure. You need to stop the bleeding as early as possible. And second thing is you need to clean the wound. And for cleaning the wound, even simple tap water, running water is sufficient. If you have an antiseptic, you can have it in iodine or chlorhexidine. All the things are available. If you can want to use them, fine. A running water clinic, and ask the person to see you, that means contact the nearest doctor after the wound has been cleaned, and you can put any cloth which is clean over it and shift it to the nearest center. Now, as a doctor, when you see this patient, what Dr. Anup has said very clearly, you have two options, the primary suturing and the delayed suturing. Suturing can easily be done by an MBBS doctor, and that there are scientific reasons for that. Primary suturing can be done, but delayed suturing if you are suspecting an infection. And don't forget the tetanus shot, provided the patient has not taken it in the last 10 years. If the patient has not taken the last 10 years, full tetanus prophylaxis. Otherwise, if he has taken in the last 5 years, you may omit that. That's what the injury is. Now we come back to burns. What are the first aid in burns which every doctor should know?
So the principle of first aid in burns is first, primarily the thing is take the child away from the source of the injury. That is, if he is in the fire, then you have to take him away. If there's a fire is in the kitchen or something like that, move him away to a quiet place and remove the apprehension. You have to again put the burnt part, the area which has been burnt, under normal running water. Sometimes there is a presumption that we should put into the cold water, which is not to be done. It has to be normal temperature, room temperature water, which is required to soothe the pain and the heat. That is one thing is important. And then again, we have various local applicants, which silver sulfadiazine, etc., which are available. If available, apply them. Give the child a painkiller, because that is the most important thing to relieve the pain and the anxiety in the child. Give the painkiller in the form of paracetamol or ibuprofen, whichever is available at the time of injury, and manage it. Don't try to break the blisters. Sometimes the blisters are formed. I would recommend that you don't puncture the blisters. Let them heal by themselves, because if that's the fluid inside the blister is a sterile fluid. So if you try to puncture it so that it settles down, there are chances of introducing infection to the blisters, and that is to be avoided.
So two things to remember what Dr. Anup has said very clearly. One thing is pain is a sign of ongoing damage. Continue putting the affected limb under the running water till the pain disappears. The time pain disappears, now you know the burning chemical reaction has gone, and then ask the child to come to you as a doctor. And second thing, blister is a sterile dressing, don't puncture it. It's a natural dressing. If there is a blister, just do a simple dressing and don't touch it. So therefore, don't tell your patients at home that they say there is a blister, ask them, please don't puncture the blister, and bring the patient to you as early as possible. Two basic principles of burn. If the burn is a simple burn, pain is an ongoing sign of inflammation, burning, chemical reaction. So continue pouring water till the pain disappears. Second is don't puncture the blisters, and use silver sulfadiazine, which you can use as a doctor, and you can give them a dressing. Third, if basic first aid in bites. It can be two common bites are human bite, which is very common in children. एक दूसरे को काट लेते हैं, and the second is a dog bite. Then we have multiple bites, but let's talk about two: the human bite and the dog bite.
In the children, dog bites are common because we have a lot of strays all over the place, and dog bite treatment is very clear and well defined. You have to obviously take the child away from the thing. Again, wash the wound thoroughly with running water, and don't poke it or don't do anything else in that, and just wash it with water, and that's it. Again, if it's a deep bite also, pressure dressing may be given, otherwise no dressing is required. Generally, I would not give any dressing on the wound unless bleeding is there. Second thing is, you have to take the child and look for the history of tetanus, toxoid if he received in the past, and depending on the category of the dog bite, we have to start the anti-rabies vaccine, which can be given by you whenever the child comes to you. Call him to your clinic and give him the anti-rabies vaccine as per the schedule which is available.
So the message is very clear. You can have a dog bite or you can have a human bite. Bite means the bite is always from the teeth. It is not, I'm not talking about panja laga diya. So whenever there is a bite using the human teeth or the animal teeth, The human contains a flora, and that flora of bacteria, if it goes to the wound, can cause infection. So the only bite where we do consider giving an antibiotic is a human bite, plus minus in a dog bite. Therefore, clean the area. You can use soap and water continuously with soap and water, with the running water, clean, 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 and clean. Take it to your GP. That will be your reaction. Suppose somebody says, "मेरे बच्चे को कुत्ते ने काट लिया है," you say, "This is what you do: clean, clean, and come to me." And when the child comes to you, your job is A, is the cleaning proper? B, does he require some antibiotic? C, does he require a dressing, a pressure dressing or a routine dressing? And next is, does he require any anti-rabies prophylaxis? And if yes, a rabies vaccine or a rabies serum. That you will decide, and accordingly manage the patient. Let's come back to a foreign body in the body. A foreign body can be in the nose. A foreign body can be in the ear. A foreign body can be stuck in the esophagus, and a foreign body can be stuck in the anal cavity or a vaginal cavity sometimes, and specifically as a part of child sexual abuse or an assault. So let's talk about foreign bodies in various areas and how to tackle them.
Before we start about the management of the foreign bodies, I would once again request the parents and all my colleagues listening to this podcast is to teach and educate the parents and their children to avoid foreign body ingestion and take steps so that the child doesn't take. Don't give them loose coins to play with. Don't give them peanuts. Don't give small kids. Don't give them peanuts and peanuts or peas to play with or eat, because they are likely to go put in the ear or put in the nose, or even if they swallow it accidentally, or it may go into the respiratory tract and it can cause respiratory distress. So that becomes a major injury, and sometimes it can lead to major complications. So, and coin, if it goes into the trachea, then it can cause problem. Even in the esophagus, it can cause problem. It can get stuck in the tubopharynx and it can cause obstruction. So this is the problem. Sometimes the children put peas or some things like that into the ears. Another which is important aspect nowadays is that we all have alkaline batteries, button batteries which we have, and they are one of the most common causes of major morbidity in the children at the moment, because if they go in and they get stuck, they cause damage to the trachea, etc., or esophagus. They can cause corrosive injuries to it, and it can lead to major complications like tracheostomal fistulas or something like that. So we have to educate the children to not to play with the discarded alkaline batteries, which are very common in almost every equipment or every item which we use nowadays, in toys or whatever. Now coming to management of it, obviously it depends on where the foreign body is gone. If it's in the ear and if it's visible outside, you can just take a forceps available, you can take it out, because as the time grows, then it becomes hygroscopic and it can enlarge. So it's immediately, if you can take it out, it's fine. Otherwise, I would advise you personally that you tell the parent to get the child to you, and then you can do it under supervision and light and with the necessary equipment. That is, if he swallows a coin, and if it's an esophagus, again you have to tell the parent to get the child to you. You get an X-ray chest done. If it's in the esophagus, I'm not much concerned about it, because it's likely to go into the stomach and then it can pass away. But if it appears there's signs of respiratory distress, etc., then it might suggest that it's in the trachea, and that's a major emergency. And then the child has to be managed by the hospital, where urgent bronchoscopy may be required, and then it has to be taken out.
So let's revise what Dr. Anup has said. A foreign body in the ear, if it is likely to be a hygroscopic, say butter ka dana, anything which you feel can swell with the use of water. Don't put oil, don't put water into it, and try to take it out. If it can't, go back to your GP, he will take it out without any problem. Simple thing. If it is in the nose, same thing. If it is hygroscopic, it will cause some problem, otherwise take it out. If it gets stuck in a foreign body in the eyes, yes. If it is burning, Pour a running water till the burning disappears, go to the hospital, go to the nearest GP who will be able to, and if he finds there is a small foreign body in your cornea or on your conjunctiva, he may take it out under light. And if you find a foreign body if he has swallowed a foreign body, and if the patient is having asymptomatic, if the child is asymptomatic, do an X-ray, and if it has crossed the esophagus, nothing to be done. Unless you want that coil, don't even follow it up. If you want the coil, next day in the morning you can get it. That's what if it has already crossed the esophagus. But if it is in the esophagus and it is asymptomatic, watch. But if it is symptomatic, that the body is trying to take it out and it is not going from the esophagus, you may have to consult a pediatric gastroenterologist who may watch or take it out by endoscopy. But if you have a foreign body in your bronchus, in your lungs, in your respiratory tract, it's a medical emergency. Don't ignore, even GPs may not be able to do that. They need to refer such children to the nearest center. So that's what most important things are when we talk about foreign bodies in children. Then we come back to corrosive poisoning. We have talked about the buttons, but let's redefine the importance of alkaline batteries and what is the first aid involved.
Alkaline batteries, again, the two things. One is the battery and another is the liquids. Now, batteries, I've told you that the children do take as in curiosity, they swallow it and put it in their mouth and it goes down. Again, I would not recommend any waiting in the case of a corrosive battery, in the alkaline battery, because they have to be taken out. Because if they stay long, they get they release acids and all that, or alcohol, and that can cause major damage. So I would recommend immediate management and removal by endoscopy, or otherwise if it's not coming out of the endoscopy, because the longer it stays, the more chances of damage are there. Now coming to the liquid alkali or acid injuries, first thing again I would like to recommend is, or request is, to prevent such injuries, because many times we keep acid at home in a cold drink bottle or something like that, or a white bottle. The child doesn't know what it is and he accidentally drinks it. So that is the major reason or mode of injury what we get in our clinical practice. So the main is not to use such liquids first thing, and if at all you have to keep it safe in a locked almirah so that the child doesn't get hold of this. Now, if there's a history of ingestion of liquid, then don't do anything. You may give a cold water or cold milk to neutralize the effect. Don't try to induce vomiting in such cases. So sometimes our tendency is to induce vomiting, that the child might vomit it out what you ingested, which is not to be encouraged, because with vomiting, leaching occurs, and there are more chances of injury by reflux of that acid to the unexposed area while the child has drunk it or taken it inside. And management would be, obviously it's a minor thing, and if your child is okay within a couple of hours, not much intervention is required. But if it's a major injury, or it has gone to the respiratory tract, then expert advice is required. What we recommend is to do an endoscopy in such children to assess the depth of the injury, and then the management accordingly is required. Sometimes you might have to bypass the esophagus and make a gastrostomy or gastrostomy or feeding, etc. But that depends upon the results of the endoscopy.
So what happens is sometimes you have to know your limitations. If there were no limitations, there was no MBBS, there was no MS, there was no MCH. The very fact government has come back to 3-year levels of education, it means there are limitations. And if you try to overpower them, and that may be the number one cause of anguish, the relations may get angry, you may end up into medical legal litigations. Therefore, if you are an MBBS, whether or not you are an expert, you need to explain to the patients, A, if it is an alkaline or battery ingestion, refer. You need to refer it to a specialized center. Patient may require an endoscopy or a bronchoscopy depending upon where it is. Timely referral is the most important. If suppose you refer it after 6 hours and some damage comes, the mob may come back and they may ransack your house or your clinic because they say you did not refer them in time. Even if you are an expert, even if you can do a bronchoscopy or an endoscopy, some MBBS do, but you need to take consent and you need to inform the patient and take the consent for that. Two, if you find any foreign body in the respiratory tract, don't wait. That means whenever a foreign body comes, first thing you should do is do a SpO2 monitor. And if you find SpO2 is less than 92, and specifically if it is less than 90, don't wait. Immediately refer the patient to the nearest center. If necessary, arrange an ambulance. And sometimes you may have to accompany the patient to the nearest hospital to A, to do your dharma, and B, to prevent medical complications. Third, whenever there is a corrosive poisoning, handle them with care. It invariably may end up with a structure. So invariably somebody may come back and say, you did not manage him, you did not give him the proper first aid. So timely refer these three conditions is very, 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 very important. That is corrosive poisoning, alkaline or acidic, which is common. Two is foreign body in your respiratory tract, specifically is the bronchus. And third is an alkaline battery ingestion into the esophagus. Here that formula that it has crossed the esophagus and it will pass on by the stool does not work. It's a medical legal emergency. Let's come back to bilious vomiting.
Now, bilious vomiting is an important sign of interstitial obstruction, and it's the most, it's a sign which everybody should watch out for. Don't ignore it in any case. Vomiting as one is bilious and second is non-bilious. Even in some cases, non-bilious vomiting is also dangerous for the child, but bilious vomiting is more so a danger sign for intestinal obstruction, and immediate management is required. Now, the various causes of bilious vomiting in children, which may vary from age to age. In neonates, malrotation and volulus is the most.
Bilious vomiting means intestinal obstruction.
Unless put otherwise.
So the message is very clear that bilious vomiting cannot be normal, it cannot be simple gastritis, it cannot be a simple food poisoning. If there is a bilious poisoning, bilious vomiting, you know you are dealing with acute abdominal emergency. Again, don't handle. If I am a pediatrician, if I am a GP and there is a call that my child has vomited a green colored vomiting, I would say, take him to the nearest hospital and I'm reaching there. If you really want to do service to him, you say, "Samne hospital pahuncho, main wahi pahunch raha hu." Don't even waste time that you should first go and see. Bilious means emergency. So this is the fourth emergency we have talked. Again, let me revise. Alkaline battery is an emergency. Bilious vomiting is an emergency. Respiratory distress is a omnia sign. Any respiratory distress is a medical emergency. And fourth is corrosive poisoning. Don't wait. And then let's come back to one more poisoning before we end. One more medical emergency before we add the surgical emergency is appendicitis. How to suspect and what to do.
Appendicitis is one of the commonest emergencies which we see in pediatric age group. And the common signs are the child is well and sometimes he starts developing pain. And now this pain generally starts near the umbilicus and then it localizes in the right iliac fossa. And it's in the early stage when the appendix is inflamed. But if it progresses and it perforates, it's likely to lead to localized or generalized peritonitis in the abdomen. And the signs would vary. The signs of this condition are obviously the histories I've told you, pain which started in the umbilicus and then it's localized in the right iliac fossa. Then if there could be fever later on, if there's a sepsis, the fever is there. Then if there's peritonitis, there's a rebound tenderness in the abdomen, there is guarding. So you have to suspect the condition, and I would go with a clinical diagnosis. Appendicitis is a clinical diagnosis and should be done so. Nowadays there's a trend to do an ultrasound. So as a general practitioner, what we are talking about, we have to suspect the condition, make the diagnosis clinical, and again refer to a center where investigations and ultrasound, if at all required, can be done and the patient can be managed.
So appendicitis in children is common. Any age group it is there, but in children it is common. A lot of links, the faulty dietary habits, the worms inside, whatever may be the reason, it's common to have appendicitis. High degree of suspicion is required. So never ignore a child who is having abdominal pain. Specifically, starting from umbilicus, going to the right iliac fossa. You can do lots of tests. I think appendicitis is one condition which is being taught to every MBBS in great detail. It's difficult to miss the diagnosis of classical appendicitis unless you have atypical appendicitis, for which you may end up into an ultrasound, specifically if the person is a young, pregnant female, where you may have to have a differential diagnosis. So don't ignore. Let's revise again the 5 things not to be ignored in MBBS. Again, I'm basically repeating them so that you mug up, you remember, you do it, and don't forget about it. Number 1 is a corrosive poisoning. Don't ignore. It can end up into a stricture of the esophagus. So therefore, don't ignore corrosive poisoning, number 1. And always corrosive poisoning is a medical legal case, because if the stricture happens later, invariably the police will come. Number 1. Number 2 is alkaline batteries ingestion is a medical emergency. Never ignore. Send him to a specialist in time. Any respiratory distress with a suspected foreign body, always look whenever there is a respiratory distress, and if the foreign body is not removed, the child may develop a lung abscess, which may be very difficult to treat, infections, and of course, the respiratory tract involvement if it is in the main bronchus with that. And the 4th is do not ignore bilious vomiting. Whenever you find bilious vomiting, refer, and always suspect and make sure you don't miss the diagnosis of appendicitis. There are more, but we decided to pick up only 5 most common pediatric emergencies. Maybe some other time we will talk about 5 more. And if you like this program, pass it on to the people. And of course, if you have mugged up, if you have remembered these 5 points, pass it on to the people yourself. Thank you. Thanks, Dr. Anup Mohta, to be here with us. We will come back next week with some more